Hello and welcome to another episode of Rings a Bell podcast. I'm your host, Kimberly Callio, and I forget everything from pharmacy school. So I invite a guest on to quiz me on a topic, and then they get to roast me on what I don't remember. The result, hopefully, is a fun version of continuing education for pharmacists. Some housekeeping off the top of the episode. I've made a little link tree that has all the links to all the things you could ever need for the podcast. You can find the main podcast platforms there. You can find the YouTube links there. You can find the socials. You can also sign up for the email list so that you just get reminded and you don't have to follow socials if you're having a little Luddite moment, as many of us are having these days. You could suggest yourself or others as a guest for the show. And new for this episode, you can find my semi-useful notes, where I take notes as I go, and I don't really make them look nice, but I find them useful. Maybe you will too. And this just in, you can buy me a coffee, which is a very chill way to donate to a creator and help them buy more coffee or feed themselves. Because obviously I'm not making any money off of this. So if you found the show to be useful to you, this is a way that you can donate to the cause. Without further ado, here's the show. I'm here today with Jenny Hsieh. Jenny is a PharmD student at Memorial University. Welcome, Jenny.
Thank you so much for having me, Kimberly.
So you're in the Memorial PharmD program. Is that a post-grad program?
Yes, it is a postgrad program. It's for working professionals, and it is a program ranging from 3 to 5 years. So it is offering a lot of flexibility for working professionals like me or you.
Okay, and where are you working as a working professional?
I am doing more of a relief right now because it's quite a heavy workload. So I'm helping Pure Pharmacy for relief, but I don't know where I'll be next couple of years, but it's a good balance of work and study.
Okay, cool. I used to work for Pure Pharmacy.
Nice.
Yeah, I opened up their Courtney store
Wow. Okay.
on the island, and then I was like, oh, I fell for a ski guide, and I'm moving to the interior. Bye. And when did you graduate from pharmacy school, and where from?
I graduated from the same pharmacy school as you did, UBC, and year 2018 for me.
2018. Oh, okay. So we were there together.
Yeah, I think
Okay.
I saw you. Yeah.
Okay. So how did you know you wanted to get into pharmacy altogether?
Wow, it's like $100 million question. I think it just naturally comes to me, realizing that I do have a big heart. I have a lot of empathy for not just my friends, my family, but actually it is extendable to people who I've never met. It is a very encouraging reward for me to knowing that I can help and also to know I can apply my knowledge to helping people.
Well, you're in the right career for helping people. And then how did you know you wanted to do a PharmD?
A PharmD.
Well, I guess you already had one. Did you get?
No, it's I'm last year BSc, so
okay.
Almost there, but not there. So it's a pretty long-winded road for me to figure out because I've thought about it and I had this thought paused, but then I never wanted to tackle it. But then it's until a point of maturity and also having lots of experiences in the community, I realized there's still a gap. I don't know how to describe it, but I feel like I probably need a little bit of a boost, some challenges for me to be able to get to the point I want. I'm still figuring out what it is, but I guess along the way of the program, I would know exactly what I'm looking for. But definitely it's a challenge, testing your brain power and your memory skills. But I think it's very worthwhile.
Yeah, cool. Being out in the community for 5 to 10 years, you definitely get into a rhythm and you see the same stuff over and over again. For me, if I ever was considering a PharmD, it wouldn't be for more of a challenge. It would be for a refresher so that because you start to feel not as confident in various disease states that you just don't see often or drugs you don't see. So that would have been my plan. But and what are you hoping to get out of the PharmD? Where are you hoping to land? Do you know?
I think I'm thinking more of like a educational role in the end. Like I think it kind of aligns with what we're doing right now. It's not educating like pharmacists. I think there's always areas that I don't know and I need to refresh my knowledge. But it's more like educational role for like students or like a university facilitator to help with more practical skills, and I think it needs to come with like the whole set of skills, not just me having some experience in the community, and I need to know that I'm competent to fulfill that role eventually. So I think I'm still young, I'm still figuring it out, so it's quite refreshing for me too. So more of an educational role for me, I think.
Cool. Hey, well, and you have a long career ahead of you, and you're living in the right place to be doing an educational role. You can, living in Vancouver, you'll be able to go do some work at UBC, I'm sure.
That's
Where I am, out in Castlegar, not so much. That's where the podcast comes in. But yeah, I'm really excited that you joined me today. And I think it shows great initiative, and shows you're on the right path in terms of what you're trying to achieve. So that's great. And you are quizzing me on anemia today, is that correct?
That's correct. Anemia. It is a very broad topic, I think. And to be honest, I don't know what it's like for you. In community practice, I've always feel like I can't really do much for my patients except, yeah, just what do you want, what type of iron you want, and that's it. That's the interaction. That's where it stops. So oftentimes, I wonder how they're doing after getting their supplements and how they probably, what their lab values may be, and are they being monitored frequently enough? And so I'm always curious about what happens next. And now I'm actually doing a project on this anemia clinical service, and I do see that pharmacists can take a role in helping patients to assess and to screen for anemia, or specifically iron deficiency anemia, which is the most common type of anemia. So I do have a set of questions I like to quiz you on, and when you're ready, let me know.
Okay. I don't feel confident about anemia because, like you say, I learned anemia. I remember learning during class, seeing the diagrams of the macrocytic and the microcytic, and I remember getting it at that point. And then I graduated,
And
vaguely remembered what salt is the most, has the most actual elemental iron in it, and that's kind of where I stand.
it's all right. That's refresh memories together. Okay, so I'll start off with the most, I wouldn't say basic, but kind of covers the basis of anemia. So as a pharmacist, while you're assessing a patient's anemia condition, what are the things that you need to consider first? So I have four options. Option A, symptoms of anemia that the patient may be presenting. Option B, assessing risk factors of anemia. Option C, symptoms that reflect the underlying condition. And option D, all of the above.
All of the above?
Bingo.
Okay.
I like to, ease it in, give you some confidence in the beginning. So maybe you can tell me why you think all of the above and probably give me some rationale behind it.
All of the above because they all kind of relate into each other. So
Mhm.
you're gonna have symptoms, but then you need to know what they could elsewise relate to so that you know that you're actually looking at a person with anemia versus something else.
Exactly. That's very well said. So oftentimes maybe not just pharmacists in general, people might think anemia is a it is a diagnosis, but it's actually not. It's a manifestation of an underlying condition. So oftentimes anemia would need to be assessed through based on the patient's history and physical examination. And the most common symptoms that we're all aware of about anemia is general fatigue, weakness or shortness of breath upon exertion, and pallor. So I do have another question about pallor later on. So I'll give you some hints here. So good job for first question. Do you have any questions for me before I move on to second question?
Well, I'm just, I guess, more of a guffaw. I didn't know that it is not a diagnosis necessarily. It's a manifestation
It,
of the.
mhm. It's most of the time it's what we're most concerned is about what the underlying condition is. So
Okay.
anemia would be, yes, it is a diagnosis, but not so much we would focus on treating an anemia. We're treating the underlying condition, and then eventually the levels will climb up to what is expected to be normal for that particular patient in that case.
Okay.
Yes. Mm-hmm.
Gotcha. Yeah. So there is still an ICD-10 code for
Yes.
anemia. It is a diagnosis, but the more important thing is why do you have anemia? Because it could
Mm-hmm.
happen for a variety of reasons.
Yes, and we might be just hitting the wrong buttons and not realizing what's going on with the patient. So yeah. So let's move on to the question. Next question. So, which of the following physical signs often indicate a more severe form of anemia? Option A, general fatigue. Option B, heart palpitations. Option C, pallor. Option D, malaise.
I'm going heart palpitations on that one.
Heart palpitations. Is there a reason why you would choose heart palpitations?
Because I would want that less than any of the other options.
Well, actually, that's a good reason. But heart palpitations actually happen to be one of the symptoms, like the general symptoms that
Oh, okay.
person, yeah. And pallor. What do you think of pallor? Any part of the body that you would describe pallor that you would see of anemia?
I would just think face, like faces look
Oh.
light gray and not very filled with vigor. That's what I would think, but it sounds like I'm wrong.
No, you're half right. Not wrong, but you're almost there. So you're right. But I do have a follow-up questions about that.
Ooh,
So
eye
how?
pallor.
Yeah, good
Is that
job.
a thing?
Yes. So specifically, what do you notice about eye pallor?
Um, I just remembered that as a word that like that
Yeah.
people don't have. Maybe the whites of the eyes aren't as white.
Oh, okay. So do you ever remember like a doctor like doing a physical examination for you and then they kind of do this and check the under?
Oh.
So the under eye, like this lower eyelid, and when you flip it over, you would see a lot of capillaries. It's filled with blood, tiny red blood cells flowing in just to bring in nutrients into your eyes. So oftentimes pallor, it like I keep mentioning about pallor, but pallor usually if you see really white area and that is closer to the eyelashes, that actually indicates a more severe form of anemia. And
Oh.
see really white. I have a personal experience because I did have that when I had iron deficiency anemia, and I did also have heart palpitations. But I noticed my eye pallor, or you call it just pallor in general, it's very severe. There's almost no blood vessels under my lower eyelid, and another sign is the creases of your palms. So this one is a bit more less it's less obvious because we do need to consider a different skin color. They have different creases, tone, so it's harder to differentiate for like clinicians, like pharmacists in general. So eye pallor is the top sign for very severe
Mm.
anemia. Can you check? I think you're good. I think you're good. I always do the check when I feel a bit dizzy and heart palpitations. So, yeah. So
Okay.
You ever heard of that before? Eye pallor? Yeah, you have, but
It rings a bell, one could say. Uh,
uh,
okay, so to recap, symptoms of anemia, you're looking at fatigue,
fatigue.
malaise,
Yes.
heart palpitations are all kind of in the
Yes.
typical presentation. But if you're looking at pallor as being defined by lack of capillary redness under the
Mhm.
eye, that's more of a severe case.
Exactly. The reason why I want to include this question is that it gives me some like curiosity about how pharmacists in a clinical setting or community setting, how can we just do some physical, like basic physical assessment for patients. So I think knowing these, I wouldn't say diagnostic, but screening like questions or something to keep in mind is actually really important for pharmacists to show that professionalism, that we know what we're doing, not just
Mm-hmm.
seeing, oh, this color of the skin tone and all that, because a lot of signs of anemia is very minute, and you have to really um, delve deeper into it, but we don't have so much time in community, so there are some obvious signs that you can look for to save some time for a patient and us.
Excellent. Well, thank you. That was very helpful.
No problem. Okay, so I'm gonna move on to question number 3. So this one is more of I don't know how familiar you are with some of the lab values. Okay, I see that face, but we'll give it a try. So which of the following RBC indices is not as helpful as other for final diagnosis of underlying condition for anemia? Option A, MCV. Option B, MCH. Option C, MCHC. Option D, RDW.
Huh. Ha ha ha. Is not so helpful.
It's not so helpful.
Um, I'm going with the most general sounding one of the M's.
Okay.
A.
A? Okay, why?
Because the other ones that you said sounded like more specific versions of it. So,
Yeah, rule of elimination. That's good. That's
yeah,
good.
yeah, no, yeah.
Yeah, you're quite close. You're just off by a letter. So
Okay.
it's actually MCH.
MCH is not as helpful as MC.
As MCV, MCHC, or RDW. I'll go into details what each term means. We can do a little bit of review. That's fine. So,
Please do.
do you remember how do we differentiate different types of anemia? There's the microcytic you mentioned, and there's a normocytic and the macrocytic. What do they differentiate by?
Um, Microcytic, I believe it refers to the size of the red blood cells. So if they're bigger, then it's macrocytic. If they're what they should be, then it's normal. If they're smaller, then it's microcytic.
Exactly. So basically, what you were saying is the size of the red blood cells. So that would be the MCV. So that is actually the most important thing we look at. Yeah, and it's okay. It's okay.
Crushing.
Yeah, no problem. So if we're gonna, go through the rule of elimination again, RDW is the red blood cell distribution width. So it does have clinical significance, meaning that once if a person has a high RDW, then it would be the only indication of simultaneous microcytic and macrocytic disorders. So it still has some clinical significance behind the RDW value. And then the MCH and MCHC. So MCH, it means mean corpuscular hemoglobin. So the other one is mean corpuscular hemoglobin concentration. So do you also remember back in the microbiology course in university, do you remember sometimes like when you look under the microscopes, there's some red blood cells that are a bit fainter and some red blood cells are a bit red? Do you remember?
I do not remember. I didn't take anything where I looked under a microscope at red blood cells.
Oh, okay. It's okay. But probably in the textbook diagrams. So for red blood cells that really lack hemoglobin, it would appear a bit like faint pink. So it indicates less hemoglobin in the red blood cells. And for the normal ones, it would appear a bit red, like redder under the microscope. So MCHC actually is an indication of how much hemoglobin is contained in like the red blood cells in general. And
Oh,
MCH, that's the one that doesn't have any clinical significance. When we order labs, we don't really look at that to differentiate different types of anemias or to figure out the underlying conditions of anemias.
okay. So mean corpuscular hemoglobin concentration is you look at a slide of a sample of red blood cells
Mm-hmm.
and you see that they do some sort of mathing to figure out how many of these are red and nice and how many are pale.
Mm-hmm. So
Okay.
there is a term hypochromia. So by definition, it is MCHC less than 30%. So hypo means it has less color. Chrome means color, hypochromia. And in general, we look at MCV, MCHC, and RDW. And MCH doesn't have any clinical significance.
Okay. And so um RDW is that saying what the spread is of the sizes?
The distribution with meaning because some red blood cells can appear bigger and some could be smaller. So it would on I think some conditions would indicate if they have a very high number of RDW, then it indicates the patient may have simultaneous smaller red blood cells, microcytic, and macrocytic disorders because the variation is very wide. So it
Oh, okay.
can indicate some sort of like conditions, two conditions happening at the same time.
Okay.
Hmm.
Gotcha.
Yeah. Okay. Okay. How do you feel now?
Worse.
Okay, then I'm gonna boost up your confidence again. So,
Oh, okay, good.
okay. So we're gonna do some like short cases. So hopefully it would, help a little bit. So I have a patient. Her name is Sarah, 34, female, and her chief complaint is chronic fatigue and brain fog. She has a history of heavy menstrual bleeding, and I've got some lab values for you to consider. So hemoglobin, we've got 125 grams over liter. So I'll let you know for the diagnosis of anemia. It's by WHO guideline. Hemoglobin less than 120 grams over liter in non-pregnant women would be considered anemia. So our patient has a bit higher, 125 grams over liter for the hemoglobin value. Her ferritin level is 22 micrograms per liter. And so I don't have anything else to give you. So my question is the patient's doctor stated her blood work was normal. Based on some recently updated guidelines, I don't know if you're aware, it's called Raise the Bar. It is supported by the Ontario Medical Association. It what do you think what is your assessment of her condition right now? Um,
I've never heard of this raise the bar thing, but it sounds to me like her ferritin is quite low.
yeah,
And her hemoglobin is normal, but probably bordering on abnormal.
yes, that's very correct. This is also a multiple choice, but you're actually right on. You're right on the answer. So, the RACE bar is a updated guideline, only adopted by Ontario Medical Association. It is because ferritin, I think in BC, our level is less than 15 micrograms over liter. Give me 1 second. Let me check my references. Uh, Historically, labs reported a lower limit of normal for ferritin based on population averages. However, the problem they figure is that the normal populations often in, don't include people who are actually iron deficient. And also, um, in terms of inflammation, inflammation can also increase ferritin, so it can mask iron deficiency in general. And this study is actually based in Canada. It means that a lot of iron deficiency anemia got undiagnosed and undermanaged. So in Ontario, they raised their ferritin laboratory value to less than 30 indication for iron deficiency diagnosis. So
Mm.
she is not anemic, but she has iron deficiency because her ferritin is less than 30. So I don't know in BC what the practice is going to look like. I think it is more conservative to say, um, the assessment would need to be comprehensive. We cannot just rely on the level of ferritin. We also need to add in our clinical decision in terms of assessing history or, based on her age, 34, and she's still menstruating. So I think, and also the symptoms that we need to pay attention, and also constant monitoring is very important for this case. So that's the question for, that's the answer for this question.
Okay, so just so I'm clear as mud on this, ferritin lab values,
Mhm.
as with a lot of the lab values we have, assume that the people that we base those reference values on were healthy. But
Mhm.
when looking back, we realize A, that a lot of the people included in that cohort were not so healthy and probably had some iron deficiency anemia. So that kind of skewed it down. And then also that there are people who could present with a reasonably normal ferritin, but because inflammation can boost ferritin due to it being an acute phase reactant,
Mhm.
we kind of have to err on the side of caution and say something a little bit higher for ferritin could still mean that you're iron deficient because you might be responding to inflammation and
Ex-
bumping it up.
Exactly. If we consider risk factors of anemia, there are so many. And the top thing that we consider is the inflammatory bowel disease. I have seen so many patients dealing with that. And I don't even need to ask any question. I just need to look at their face. Their face is pale as a piece of paper. And it is like a warning sign for me. And I would, in that case, I would step in and ask, how's your iron doing and how's everything doing? And again, I think it's like how they're describing the raise the bar thing as iron deficiency anemia is almost like a silent disease. Not so much people would consider it as a very important situation in our like day-to-day basis, but it is something that we need to start paying attention to. So yeah, okay. My next question is also a case study. So now we're switching gear to a male. His name is David, 42. He is showing his tongue out to you because he feels, well, this is what we always see in the community. It's like, look at this, look at that. So he's telling you that my tongue feels smooth and burns when I eat spicy food. Smooth and burns. So that's to keep in mind for now. And when you check his tongue, yes, you see smooth and very smooth and red tongue, and you know that there are a lot of papillae on our tongue. They're all gone for this patient. He's taking some medications here. He is taking metformin, 1,000 milligram twice a day for 5 years, omeprazole, 20 milligram daily. So my question is, for this sign, what we call atrophic glossitis, coupled with medication history most strongly suggests. So option A, iron deficiency anemia exclusively. Exclusively. Option B, vitamin B12 deficiency, likely secondary to medications. C, it's called thalassemia. I'll talk about thalassemia later, minor. And option D, anemia of chronic disease. So what would your answer be?
I think it's B12 deficiency secondary to the omeprazole and the metformin.
Good job. So that is the right answer. Yay! So based on my follow question is based on your speculation, what lab would you order for this patient?
Whew. I want the mean cell volume
Okay.
one for sure. I want a B12 level.
Okay.
Um, I guess I still want a ferritin and all that
Yeah.
other stuff just to rule that out.
Exactly. That's actually really well said. So, because we want to rule out, we also want to rule in. So, ferritin definitely, MCB, B12, and is there anything else you want to order?
The RDW and
Sure. Yeah, that would be okay. Yeah, that's I think that's part of the I'm trying to remember lab requisition form. I think it's part of our like scope of practice to order the lab. So, ferritin, would you want to order iron? Iron?
yeah,
Okay, okay, good. Yeah. So we got a couple marks for that. So yeah,
leading the witness.
yeah. So definitely you need to order bit like what we discussed. So to rule out. So yeah, so that one is more straightforward because it's kind of giving you out the clues metformin, PPI, and the tongue. So moving on to our next case, a bit older, male again. His name is Robert, and he has rheumatoid arthritis, active flare, and lab values: ferritin 60 micrograms per liter, CRP 45 milligrams per liter, very high. So according to these lab values, how do you interpret this ferritin level for him? Option A, normal. Inflammation has no effect on ferritin. B, iron deficient, inflammation, inflammation. And maybe I will also, should I let you know the cutoff? Okay. Yeah. So option B, iron deficient for inflammation. Option C, iron overload. And D, invalid results.
Um, Not overload.
No.
That's for sure. I think that he is, well, just what symptoms does he have? Does he have any symptoms of iron deficiency?
Not really. No, not in this case. Not in
No.
this case.
Okay. I mean, I feel like he could have normal ferritin, but it could also be, you know, super high. Like, how high does it go because of the CRP? Does it bump it 50%, 30%?
Yeah, that's the key question to ask. So for chronic inflammation, the ferritin level, if it's less than 100 micrograms per liter, then that is an indication for this type of patient to show iron deficiency. So that level
Mm.
is a bit higher. Like we mentioned about how the inflammatory, like the cytokines, can increase ferritin levels in chronically inflamed patients. So that is the question I need to ask. So I wasn't sure if I should give it away to you, but we do need to know what type of patients and what type of lab values we need to refer to while we are, checking when we get back the lab results, and then to, give the better recommendations and referrals when necessary. So yeah, so that would
Okay.
answer for that question.
So if a person has, so say we had the same sort of person, but he wasn't in an active flare at the time, and his CRP was like 15. So it's
Mhm,
high, but it's not super high.
mhm.
Do we assess that ferritin differently?
I think it depends on the patient's baseline, to be
Okay.
honest, because every patient has different, even for normal patient, like normal, otherwise healthy patient, they would have different baseline for them to start off with. So, I think in general, the chronic inflammation, like that values, it's for just in general, like average populations. So I wouldn't say there would be another value for active flares and another values for just what we call like maintenance phase.
Okay. So if we have any patient who has a chronic inflammatory condition, we would consider that they have to look at their ferritin
Higher
in
just.
the higher ranges. If you're less than 100, we're concerned.
Hmm. And that's
Got
based
it.
off from the therapeutic choices, the guideline that I referred to.
Okay,
Mhm.
cool.
Yeah. Okay, let's go to our next example. We're switching off gear to our younger population. So I'm covering all populations here. So patient is Leo, and he is 4 years old. And his lab result is ferritin 18 microgram per liter. 18. So it's very straightforward. So what is your clinical decision based on the information I gave you? He's normal, option A. And option B, iron deficient. Option C, let's monitor for a year and we'll see. Option D, physiological anemia. So, but I don't think I mentioned anything about the symptoms. So what is your answer?
So just a 4-year-old with a less than 15.
Yeah.
I don't know the reference values for a 4-year-old, but my guess is that they would be requiring even higher levels of iron to meet their demands in their body. So I'm
Uh-huh.
going to say he's probably iron deficient.
Yes, he is iron deficient, but the cutoff is actually lower. It's
Oh,
less than 20. But you are
okay.
right because the little body is like developing and growing. So a lot of times we would imagine it just like some of the enzymes in like the CYP enzymes or some of the enzymes that it is actively like functioning. But in this case, it's actually a lower cutoff for our our peds. Hmm.
Okay.
Less
And so is that consistent across the raise the bar, or is the raise the bar only for adults?
Razor bar is only for adults.
Okay. So non-raise the bar adult BC, you're looking at ferritin less than 15,
Hmm.
less than 20 for peds.
Less than 20 for peds. It's more of a that would be a number that I refer to the therapeutic choices guideline. So
Okay.
the razor bar is uh, it's very how should I say? It's more of like something for the clinicians to keep in mind. Um,
Okay.
to assess and also include your clinical decisions along the way. But because I don't have any reference for kids right now under the razor bar category. So
Okay.
in general, less than 20.
Okay. General less than 20 in peds.
Mhm.
So he's iron deficient because he was 15,
18
18. Gotcha.
borderline. Okay. So we're going to talk about the thalassemia right now. So case number 5. It's a term that you probably have never heard of. It's the Mentzer index. So it's spelled Mentzer, Mentzer index. So it is a value calculated by dividing MCV over RBC. So the MCV, it's the size of the red blood cells over red blood cell counts. Okay, so if that value is less than 13, then it would indicate diagnosis of thalassemia. So keep that in mind for now.
Okay. So if you have mean cell volume that is not, it needs to be 13 times greater than your number of red blood cells.
Exactly.
And that indicates that generally you have a pretty good
Thalassemia.
size.
Yes,
Okay.
thalassemia. Mhm. All right. So our patient, his name is Ken, 24, male, Southeast Asian ancestry. His lab values hemoglobin 105 grams over liter. So according to the WHO guideline, the hemoglobin in male, it has to be if it's less than 130 grams over liter, then it would be a diagnosis of anemia. So hemoglobin for him it's low. MCV 65, quite low, very low. RBC count 5.5 times 10 to the power of 12. That's very high.
So he's got thalassemia.
Yes, he does. So I'm trying to introduce this idea because I'm going to ask you something about thalassemia later on. It's more on the genetic side of thalassemia. So maybe I'll talk about it a bit yeah, very soon. But yeah, so the Mansur index is a index that we refer to when we decide whether patient has iron deficiency or thalassemia, because you remember microcytic anemia, it not only includes iron deficiency anemia, it also may include thalassemia because of the smaller sizes of our blood
Oh,
cells. So there is also a very important clinical step where you treat because it might be giving misleading values for under thalassemia. So it also is quite quite of a safety concern if we end up giving too much of the wrong thing for a thalassemia patient. But I'll tell you more about it later.
okay. I look forward to that because I am
Like
confused.
So the next case is a pregnancy case study. So she's 12 weeks pregnant, and her name is Wei, W-E-I. Her lab results show ferritin 35 micrograms per liter. In pregnancy, a ferritin less than 50 microgram per liter often warrants A, stopping iron, B, initiating low-dose iron to prevent depletion due to high fetal demand, C, referral to hematology, D, testing for hemoglobin H.
Um, so the number I couldn't hear very well. The number is 5050?
50, 50.
50. Less than 50 in pregnancy, I would say you're initiating therapy low dose.
Exactly. So,
The advantage of having had a child and had to treat.
oh, right. You do have the experience. So, yeah, in this case, we need to treat our patient early, because 50 is the indicative value that we need to treat iron deficiency anemia. Um, moving on to the next question, because
Oh, okay.
yeah. And so our next question is we're going to touch base again on thalassemia. And
Okay.
for this part, I'll also touch base on how it would be relevant for pregnancy. So for this question, a patient, his name is Ken. His ferritin is 450 micrograms per liter. If the doctor prescribes iron, what is your action? And this patient has thalassemia.
I think it's a bad idea.
Why?
Because you can get overloaded on ferritin.
Exactly.
And then you'd have to, like, there are people who have familial conditions. I can't remember what that's called. But they have to take medications to lower their ferritin because they produce too much.
Exactly. So iron in this case is actually toxic. And this patient has thalassemia. So I'm going to reel back to what I was talking about, the hemoglobin disease, thalassemia. So there is a study in BC, and they looked at how much population in BC is affected by thalassemia. So it's about 10% of the BC population has Southeast Asian ancestry that has this type of disease. And it has become a major public health interest. So that's why there are several studies that are looking into it. Believe it or not, it is actually it has some genetic disposition in it. So there's two types of it. There's the first one, deletional, and the other one, non-deletional type. And it matters because patients with non-deletional thalassemia, where the gene is mutated rather than deleted, generally has a more severe course. They have higher rates of iron overload and complications like gallstones. So that's also the reason why in the patient that we just talked about, we shouldn't push more iron into the patient's bloodstream because it can cause toxic levels of iron in the body.
Okay, so is there a thalassemia where they don't have too much?
Yes, there is, but for the non-deletional type, it actually has more than usual iron stores in their
Okay.
stream. So we do need to pay attention to it because sometimes, like I said, under microcytic anemia, it's not just iron deficiency anemia. There's also thalassemia. So if we are confused or if we don't screen enough for the patient and we just give more and more iron, it would actually make the patient more sick. So again, the same study, the same BC study found that 3% of patients with the deletional the thalassemia required blood transfusions during pregnancy. And this is a massive deviation from the general population rate of 1.25%. So that's if there's a patient with microcytic anemia and who's not responding to iron, then probably we need to think about another diagnosis, which is thalassemia.
Okay. So do you have a flow chart or something that maybe you can send me and I can put up
Yeah.
for people to understand? Because I might need you to walk me through, like, so we have microcytic anemia,
Yes.
which means the red blood cells are smaller than they should be.
Yes.
And that could be because so you can have that while also having iron overload and it's thalassemia. Is
Yes.
that a thing? Okay.
Yes. The non-deletional type of thalassemia.
But I guess if you're in what we need to know as a person who's going to be in community pharmacy, which is who this podcast is for, if you've
Yes.
got microcytic anemia but a high ferritin, it's like, okay, pump the brakes. We're not giving any iron. We're referring.
We have to refer because it means that we're not doing anything right for the patient.
Okay, got it.
Yeah. So that is the part where I don't know how often that's going to look like, but considering it's like 10% of the BC's population, I thought it's quite concerning. Like we probably as pharmacists also need to know about this when we order the lab
Well, and especially depending on where you work, right? Like if you're
Um,
working with a lot of Southeast Asian patients, you're going to have
exactly.
a higher proportion.
Exactly. Okay, and probably we'll end on two more questions. We'll do two more questions, and will that be good?
Yeah.
Okay,
Yeah.
awesome. So I think you'll find the next two questions a bit more less challenging. Okay, so we have a patient. Her name is Jessica, 20 years old, female. She has a diagnosis of iron deficiency anemia. So she has been taking ferrous sulfate, 300 milligram orally, 3 times a day. However, she complains severe constipation and nausea. So, based on there's a mechanism, what we call hepcidin mechanism. Have you ever heard of it?
Yes, that's what's going to reduce absorption in
Mhm.
the intestines if you take it too frequently.
Exactly. So, based on this mechanism, what is the best recommendation you would give to the patient? Option A, take with food, dairy. B, switch to alternate day dosing, which is like every other day to improve absorption. Option C, switch to 3 times a day liquid iron. Or option D, just add a stool softener and just keep the same dose.
Um, every other day.
Mhm. Yeah. And hepcidin, like you said, when we ingest a large dose of iron, there's this huge spike of hepcidin released from the liver. So hepcidin, the molecule travels down to the line of the gut and it binds to a protein called ferroportin. So the ferroportin, it's the one that is it acts as the only exit door that allows iron to move from the gut into the bloodstream. So as the hepcidin binds to the ferroportin, it kind of traps it and decreases the absorption of iron. So it's not good. So that's why we can try the alternate dosing to reduce the dose a little bit more for the patient.
Okay. Yeah. So allow that patient to have their iron less frequently and not have to deal with the bowel side effects of the constipation, but also when they're taking it in, they're getting more iron. It's not just
Exactly.
getting all blocked. Hello. Just popping in here with a couple of helpful notes from Up to Date about oral iron preparations. Because I think as pharmacists, we love to get deep in the weeds about things. But if you look at Up to Date, it is very simple and very clear about giving oral iron. So they say actually, efficacy is only marginally different between daily, every other day, or Monday, Wednesday, Friday. You likely get fewer side effects with every other day, but if your patient has trouble remembering which day, you can just get them to take it every day. The big thing to remember is that there is no value in taking more than one dose per day. And then we also get told all the time that there's this newfangled iron. It's way better. It's going to give so much better absorption. I'm talking about your Ferromaxes and your heme iron. Um, According to Up to Date, Ferromax and the heme versions are not actually superior to just a regular old salt. In fact, they did a small RCT in young children, and ferrous sulfate, not even fumarate, sulfate, actually outperformed Ferromax. So yes, you may get less metallic taste from a heme or a polysaccharide, but you can also just get that from a liquid form, although liquid kind of tastes awful. Up to Date also cautions that there's a iron out there called proferrin, which is a heme iron polypeptide, so combining the heme and the polypeptide situations, and they're cautioning it has not been evaluated clinically, so don't recommend that. Most importantly, they're saying don't use an enteric-coated or sustained release as they release their iron too far distally in the GI tract, and absorption happens in the duodenum and the upper jejunum. That's all I got for you for now. I will be back later.
Exactly. So moving on to our last question. Her name's Amina, 45 years old, female. She's taking levothyroxine pantoprazole, and recently she started on ferrous fumarate. What would you be more concerned right now about her medications? Option A, take all three with breakfast. B, separate iron from centroid by 4 hours. C, stop Tecta, pantoprazole. And D, take iron and Tecta together.
Sorry, what am I more concerned about, or what do I think is a good thing to do?
What is a good thing to do?
So the levothyroxine will not do so good with the iron together. So I would separate those. But then the Tecta, I mean, we always want to get rid of Tecta if we can, because you need acidity to absorb the iron. So it's going to always sort of be causing a problem.
Exactly.
So, and it's the levothyroxine is reducing, it's the absorption of the levothyroxine that will be changed, and it's a consistent, like if you just started taking it always at the same time, then you would just adjust the levothyroxine accordingly and just keep it
Mhm.
stable. So I would say Tecta is my bigger concern.
That's right. Because we also need to know, probably it's like another follow-up question for our patient. How long you've been on it? Why are you taking it? Are you feeling okay with regard to the symptoms? Are you treating with Tecta? So that's another conversation that pharmacists can have with the patient. Just, follow up and to remove what's not necessary and keep on what's necessary for the patient. So good job. So that's the right answer. Yay! You survived. I
Yay!
survived too. Yeah. So I don't know if that would do like justice for anemia because it's such a big topic, but I needed to, pick the most interesting and the most fascinating things that I think and introduce on this platform. So yeah, I hope you enjoyed my quiz.
I did. I did. I feel a lot less sort of out in space, floating around, being like, "What does it all mean?" This has been very, very helpful, and you know, intuitively looking at an iron deficient or like a not iron deficient state, and knowing that myself, I felt like crap. This raise the bar thing makes a lot of sense, but I had not heard about it. I was just sort of struggling against the iron fist of our diagnostic levels here. So, yeah, that is great to know that there is some sort of room to push back on that.
Hmm.
But I really appreciated you've given a nice overview. And
Yes.
then if people want to deep dive further, they can.
Hmm.
Psych! You didn't actually think I was going to leave you hanging like that. Get you to go do your own deep dive? I know my listeners better than that. I know you're listening on your way to work after dropping your toddlers off at daycare, and you're not going to go do another deep dive. So I have gone and gotten a summary for you, and I'm back. I'm going to go over red blood cell anatomy real quick, and then I'm going to go over the different kinds of anemia broadly so we can center ourselves in the conversation that I'm having with Jenny. So we're in the bone marrow, where stem cells are converted into red blood cells. The final product, as a reminder, has no nucleus, is biconcave, so it looks like you took a disc of clay and squeezed the middle into a little button. And of course, they're filled with hemoglobin. Hemoglobin is a tetramer of 4 polypeptide subunits called globin chains. There's alpha chains and beta chains, and each globin subunit contains an iron atom bound to a heme molecule. To get onto the hemoglobin, iron needs to be absorbed from the intestine, and this absorption process has a negative feedback component, aka hepcidin, which we talked about earlier. So hepcidin is produced in the liver in response to high iron stores, but also from things like infection and inflammation. And it goes and tells the body basically quit absorbing so much iron and also quit releasing it from storage. We've got too much floating around. So to get to the form of a red blood cell, which has no nucleus and is this little disc with hemoglobin, you need to take a stem cell in the bone marrow, and it goes through replications and a transformation from the stem cell into the red blood cell. And that involves a whole bunch of DNA synthesis, a whole bunch of protein synthesis, and a whole bunch of division, which requires a pretty delicate dance between how much the cytoplasm is being formed and how much the nucleus is being formed. And then sort of at the end of that dance, the red blood cell kicks its nucleus out, and then that's the final form. It is a red blood cell at that point. And then it goes out into circulation, it does its thing, and then after about 120 days, it's too old, it's not very helpful, so it gets recycled through the spleen and the liver, and the little parts that it gets divided into can go make new red blood cells. So that's a very basic high-level overview of how you form red blood cells and what they do and where they go. But you can see that there's lots of places where things can go wrong, so therefore many different types of anemia. And I think what is confusing about anemia is that there's a lot of different ways to talk about it. So we can talk about it in terms of how the red blood cells actually look, which is often a starting point because that's how you would do a lot of the diagnosing. You would be talking about it in terms of microcytic, normocytic, macrocytic, how many red blood cells are there, what's your transferrin saturation. But you can also think about it in terms of the pathophys. And so I'll talk about the pathophys part now, and we can kind of layer it on top of the microcytic, macrocytic classification. So from a pathophys standpoint, you either don't have enough iron, so that's your typical iron deficiency anemia. Maybe you physically don't have enough red blood cells kicking around, or your red blood cells are misformed or defective in some way. So if we think of the pool of red blood cells, that could drop either because you're not making enough in the bone marrow, so that would be called aplastic anemia, or you're losing too many, and that's in the case of either blood loss or something is destroying them, and that would be hemolytic anemia. And then when it comes to defective red blood cells, there are many versions of this, and we've already talked about 2 of them, so I'll just summarize those quickly. We talked about B12 deficiency causing a macrocytic red blood cell. This is a form of megaloblastic anemia. When the red blood cells are maturing in the bone marrow, they're supposed to divide rapidly, and they're supposed to become progressively smaller as they mature. But if there's impaired cell division, such as when you're lacking a key nutrient, you can lose the intricate balance between the cytoplasm maturation and nuclear maturation. So you end up with a big immature nucleus as compared to the cytoplasm. And we most commonly think of this in terms of B12 or folate deficiency, but it can also happen due to copper deficiency. And then there's a bunch of other disorders that can cause it. So that's your megaloblastic anemia, shows up as macrocytic. And then another version of malformed red blood cells that we talked about is the thalassemia. So in thalassemia, the globin chains of the hemoglobin don't form properly. Your red blood cells are formed all goofy, and then in a lot of cases, those red blood cells get destroyed. So in a severe case of thalassemia, the blood smear will have a decrease in red blood cells, so your number will go down, and many abnormal looking cells will be there due to the malformed hemoglobin. And then there will even be some cells there with nuclei, which they're not supposed to have. The nucleated cells show up as the bone marrow foregoes quality control in favor of getting the red blood cells out as fast as possible. They're like, hey, we're not making these right, but there aren't any red blood cells around, so let's just pump them out. But if you have a mild case of thalassemia, you'll just see microcytic and hypochromic, aka pale looking blood cells, and it can be hard to tell if it's a simple iron deficiency or thalassemia. Now for the iron overload situation. The medical term I was trying to remember is hemochromatosis, which just means that your body is storing too much iron. You can have hereditary hemochromatosis, or you can have a secondary form from other conditions or situations. In thalassemia, despite being anemic, you can still get iron overload. I know, rude. In a severe case of thalassemia, you're dependent on blood infusions and just getting a whack load of iron in from the transfusion process. So that's how you would get hemochromatosis there. If you manage to not need transfusions, though, because you have a milder case of thalassemia, again, you can still get iron overload. And that's because you don't have proper erythropoiesis, so you don't have proper negative feedback through hepcidin, and you end up absorbing too much iron. This is the more dangerous version and what Jenny was trying to point out with her question, because the milder cases can be misdiagnosed as just iron deficiency anemia. And if we treat with iron, these people are already at risk for iron overload, so you could make that situation quite a bit worse. That's all I have for you for now. Back to the show.
Yeah, I think it's also a good learning opportunity for me because I always feel like anemia is always a shaky topic for me sometimes. And I think because of the project I'm doing, I do notice, wow, pharmacists can actually play a role in it. And we don't know what it is yet, but I think just keep on learning and pushing for our scope of practice. I think that's also really important too.
Mm-hmm. So the project that you're doing, what is have you finished it? Do you know what it is going to look like?
I do. I have a proposal. I have a plan. And basically, I know that a pharmacist cannot diagnose yet for anemia because I do understand why. Because after learning, like relearning everything, it's such a huge topic. And also learning about thalassemia, it can be quite complicated in some sense. So I do see some interdisciplinary team would be a more appropriate way to tackle anemia altogether. But I do also see there's a gap of care, meaning that a lot of times patients just come to the pharmacy and pick up what their naturopath or prescriber or nurse practitioner wanted them to get. And the conversation just ends there. So I am proposing that perhaps pharmacists can play a role in terms of encouraging screening and also catching the higher risk groups and to encourage them why they need to pay attention. Like what I mentioned, did you know that ferritin could be affected by inflammation and all that? And also high risk patients, definitely women, menstruating women and also elderly too. And so also vegan population. So I did look into some of the studies that look at what their levels we need to be aiming at for ferritin or for any other values and what type of supplements are actually good for them because there are a lot of restrictions and we need to consider. So I will be implementing my business plan in my practice. So I'll find out what it looks like, but I don't know if it's going to be popular or not, but I am looking forward to it.
Okay, well, I wish you lots of luck, and maybe, in 6 months or a year, we can have you back on with an update about how it's going and what you've learned. Okay, thank you so much for quizzing me, and being nice about it too.
Oh, thank you. No, thank you so much.
Thank you for sticking around and listening to another episode of Rings a Bell podcast. I hope you enjoyed it. As I mentioned, my link tree with all the useful links can be found in the show notes below, as well as a link to follow Jenny on LinkedIn. She's a great follow, pretty active on there, very smart gal, obviously. A reminder that in this episode, a new thing is that I have my semi-useful notes. I decided not to go over all the drug causes of anemia, but I have posted the up-to-date chart of the different mechanisms for drug-induced anemia in my semi-useful notes, and I've also layered them, some of the big causes, onto a mechanistic diagram of anemia. So hopefully that helps. If you would have preferred that I went over it verbally because you'd prefer just to listen, please comment. And as per usual, I actually do welcome feedback. I would prefer constructive criticism to just like shouting into the wind. So, with that said, thanks for listening. Have a great day. See you later at some point when I get back to another episode.